we are talking here about immunotherapy in a pediatric cancer in neuroblastoma. And we have a big high-risk frontline trial, high-risk number 1, that addressed previously 2 immunotherapy questions on how immunotherapy should be given most adequately. So in Europe, we developed dinutuximab beta, and in the US, there is another molecule, dinutuximab, but they are functionally and molecular different molecules, although name-wise quite alike. In the earlier results, the 2-year event-free survival rates of both products in the hands of each of the cooperative groups in the US and also in Europe looked very much alike in terms of survival rates, reaching about 60%. And we have, so we were thrilled by the outcomes in a high-risk disease. It's noteworthy here to say that in the US it was used in a combination with IL-2 plus GM-CSF, and in Europe plus IL-2 because GM-CSF was not available, and we also used IL-2 subcutaneously to reduce the toxicity profile. So as things evolved over time, and these were 2 outcomes that we reported previously at ASCO as an outcome of 2 immunotherapy randomizations, that IL-2 does not impact the outcome, and that this can be safely left behind. And so this is the important message that we want to bring, because our next step was really, once we had ruled out IL-2 for the toxicity burden, to further investigate if side effects of the antibody that has a couple of side effects that are important to the children, most importantly pain, but also allergic reaction as one of the predominant ones, that this again could be significantly reduced by prolonging the infusion time from previously 5 days to a total of 10 days. But the total dose of the antibody given per cycle with 100 milligram per meter square, total cycle dose stayed the same in both application modes. And so we have an 8-hour infusion in the short-term schedule, and we have a 24-hour infusion over 10 days in the long-term schedule. The most important clinical impact that we could demonstrate here, even if we left out the use of IL-2, so we lowered the toxicity profile, by looking at the total cohort that we have in the trial, that we had a significant improvement of 10% by using the long-term infusion scheme. So that was possible that we took the populations from both randomizations in the high-risk arm and made it also very clear for interfering risk factors, because there were 2 high-dose regimens in question previously. So we focused on busulfan-melphalan treated patients. And notably, one also has to remember whoever was ready to undergo high-dose treatment would have cleared the bone marrow and only have 3 skeletal MIBG positive spots. So having said all this, we were coming out with a cleared population that we used for this comparison of 345 and 360 patients out of these previous randomizations. And this is where we see this very clear advantages in event-free survival, which is in the overall group 10%, and in the stage 4 patients solely focused on 11%. And that means also, if you translate it into the cumulative incidence of relapse rates, also to translate in advantage of more than 10% of reducing effectively the relapses in this very population. So we thought that this is a major finding that can be explained by a number of actions in the background. We do believe that immunotherapy works differently, and the prolonged scheme gives a chance to achieve a higher AUC and a higher factor activation over the longer time span, finally resulting in these markedly improved significant results. I think for the future, or what I would like to add, is the point of the 10 days of treatment that it sometimes come into discussion, and I think it's very important to know that it's for the first cycle important to have the patient in the hospital to understand the individual's patient's tolerance. But the profile of toxicity reaction goes down cycle by cycle. And after cycle 1, there are more and more patients that can be treated in home care with pump infusion systems. So it's not a day-by-day cost in the hospital, but they also can be safely released in a home care setting. I think that's a very important take-home message. And obviously, we are only happy if all the patients survive. So this is now subject to early trials and investigations of newer immune modulators that hopefully would increase the efficacy without increasing toxicity.